You're tuned into the Unnecessary Harm podcast, where we drill down on issues of substance use and its cultural impact. Your host, Shane Varcoe, Executive Director of the Delgado Institute, with over 40 years experience in youth and community work and a passion for building resilience.
Welcome back to the Unnecessary Harm podcast. Good to have you with us. And if you're chiming in for the first time, welcome on board. Love you to subscribe, engage in our LinkedIn newsletters and also on Spotify, but by all means connect and share. Today's guest represents something very rare in the alcohol and other drugs space. Recently, a senior government minister and policy developer who has staked her career on the recovery-oriented model at a time when the manufactured policy consensus in much of the English-speaking world still tilts towards a misused harm reduction only mechanism. In much of the world, alcohol and other drug policy is drifting in one direction: more tolerance, more access, more supply. The language of the new harm reduction has become the default, and organisations and even governments that dare to push back are often dismissed as ideological or worse, labelled as uncompassionate. Such is the manipulation of propagandised narratives. And we're used to those here on the Unnecessary Harm podcast. As CEO of CORE, Canadian Centre of Recovery Excellence, Kim is not just advocating for a different and better approach. She is building the evidence base to defend and sustain it. CORE is a Crown corporation established by the Alberta government to research best practices in recovery, evaluate what works, and build a rigorous evidence-based base for recovery-oriented systems of care. Kim is a former Deputy Minister of Mental Health and Community Wellness in Manitoba and one of the most senior figures in the Canadian mental health and addiction policy. For an Australian audience, harm reduction became entrenched as a default policy framework decades ago. Alberta offers a compelling counter-narrative. Kim can speak to what a government looks like when it decides that recovery, not just risk mitigation, is the goal, and what it takes institutionally to take that up with data. She has spent her career asking a simple question that too few policymakers are willing to sit with. What does it actually take to get people well? Kim Kaufmann, welcome to the Unnecessary Harm podcast.
Thanks for having me, and a great introduction.
Oh, our pleasure. Great to have you here. And again, we met for the first time in Vienna this year at the CND, the Commission on Narcotic Drugs, number 69, which was really a really special time. How did you find that? Was that your first time there?
Yeah, so that was my first time attending the United Nations Commission on Narcotic Drugs. I attended as a representative of the Canadian delegation on behalf of the province of Alberta and our organization CORE, or the Canadian Centre of Recovery Excellence.
Yeah.
And I hope to have the opportunity to go back in future years and meet wonderful people like yourself and others.
Yeah, it was good. It was a bit low attended this year because of what was happening in the Middle East, and a lot of people couldn't transit through that sector, so there was a bit light on, and we did a presentation there as we did last year. And it was good, but it was great to connect with a bunch of new people, and it was, again, I think it's providential that we connected and you're here today as a result, so it's really good to have you here. So do you want to kick into the interview, get a bit of a background, and as we go through today, learn a little bit more about what makes you tick. I think that's a really key issue here. Every guest we get on has a story, and the stories vary, and they're quite remarkable in their own right. But the question, the opening question is a bit tricky one. So, when you wanted to grow up, did you want to be a drug recovery expert? Was that your goal in life? Where did your journey into this complex and important arena begin for you, Kim? When did that start?
Yeah, that's a great question. I've always been fascinated by mental health and addiction, and started my career, though, wanting to become an actuarial accountant.
Wow.
And my mother said that I would be too much of an introvert if I did that, and therefore I needed to do something else. Because I needed to be around more people than just books and math. And so I headed into a path as an occupational therapist. And then because of my interest in mental illness and addiction, started as an occupational therapist at a provincial psychiatric hospital in my home province, which was Manitoba. And then from there, I had assumed I would stay in the area for 5 years. and then never left. So it's 20 years later, and I'm still working in the same space.
Wow. So it's interesting how the different nudges we get from the different quarters in your space. It was mum. No, babe, you can't do this. You need to be with people, not with books. I like, God, your mum. Well done. That's a great story. Now, you've had a lot of learnings, obviously the occupational therapy side of it, and your fascination, your words, interest with mental health issues and addiction. And they're often co-occurring. We know that. So it's fascinating. Which starts first, the addiction and the mental health, or mental health and the addiction, and it's a convoluted mix that presents in different ways in different settings. We understand that, but the learning journey. What were some of the key moments for you? Like you said, you spent upward of 20 years, and what were some of the, if any, it may have been a gradual, immersion and a development of understanding and a gathering of data and a gathering of insight. And that's wonderful, of course, and important as we all learn and grow in whatever role and vocation we find ourselves in. But were there any, like moments, aha moments for you, like during your various seasons of going, wow, what is that all about? Or, gee, I did not see that coming. Or, that's interesting. What caused that? Is there any kind of those moments in your experience?
Yeah, absolutely. So I started as an occupational therapist working at the front lines in the provincial psychiatric hospital. Interestingly, my sister is also an occupational therapist, and we shared 2 full-time jobs at that hospital, both working in mental health. At some point in time, we opened a private practice as occupational therapy consultants, doing a lot of insurance-related work while we still worked our full-time jobs at the psychiatric institution. And then with time, she had children, and I took a bit of a leadership path. My sister took over as the owner and the sole CEO of the private company, and then I worked my way through a leadership path. So I moved into the director of operations for the provincial psychiatric hospital, which had 1,000 staff, 252 patients, so a big facility. And then from there, this is kind of when it started to get interesting. I was recruited to become the CEO of a smaller psychiatric hospital and service provider. And this organization was called Eden Healthcare Services, and it had just a brilliant model of helping individuals with severe and persistent mental illness to achieve recovery. And when I say recovery in the context of mental illness or addiction, I'm talking about living a satisfying, hopeful, contributing life, not just the treatment of the disease. And so at Eden, I was appointed as the CEO for that organization, and it was really incredible because we had the opportunity to help people become well. It had inpatient, outpatient, community mental health services, housing, employment, and counseling services. So we were able to help people at any point in their trajectory to live a better life, and also to prevent them from being rehospitalized and helping them achieve the goals that they really wanted. I still teach at the university to this day, and I teach a group of occupational therapy students. Our model as occupational therapists is really about that holistic approach to health and wellness, and so I had the opportunity to lead that as CEO. And so I was responsible for that organization that had that wraparound services for 1/5 of our province in Manitoba. And then the government created a new Ministry of Mental Health and Addiction in January of 2021. And I thought, wouldn't this be cool to be able to take this model and be able to expand it to the entire province and be able to offer a recovery orientation or recovery oriented system of care for everybody with mental illness and addiction in this province. And so had the chance to do that. I was a successful candidate, applied for the job, became the deputy minister, stood up the first standalone mental health and addiction ministry that was kind of full functioning in the country. Wow. There was another ministry, but they were just a policy shop. So did that and had great success in that role, helped to create a strategy to enhance the system to be more recovery oriented and see through execution of that strategy. And then we had a government change in October of 2023. And the new government ran a campaign on committing to more of a harm reduction approach, opening the first supervised consumption site in our province. And in the end decided to part ways with me, which was probably in my best interest as well. And then I was quickly hired by the government of Alberta to stand up this new organization. And so a great opportunity, stood up the new organization, and then was appointed as the CEO of the Canadian Centre for Recovery Excellence in Alberta. And our organization is really important because over the years, what I've learned is, one, we really need to think about recovery-oriented systems of care and building systems to help people get well and having that relentless pursuit of recovery in all that we do. And two, we also need to ensure that we're rising up and enhancing the standard of care for those with mental illness and addiction. For some reason, we've accepted a lower standard of care. We've accepted a lower standard of evidence than you would typically see in that of the health system or physical medicine. For some reason, we've said, well, it's good enough. We don't really know what the unintended consequences are. We think it helps people, but we're not really sure. And we haven't really assessed things over the long term. And so our organization has the ability to do that.
Awesome. Well, that was a beautifully deployed response. You've actually answered our next question, because I wanted to talk to you a little bit about this, your Selkirk experience and obviously Eden, which you've alluded to. Again, we're going to talk about the policy shift and what that has meant for a lot of sectors around the world. And Australia was arguably the first to create and identify the term harm reduction as a pillar of our harm minimisation strategy back in 1985. It has three pillars. A lot of our listeners have heard this: supply reduction, demand reduction, and harm reduction. But the term harm reduction and harm minimisation have become interchangeable. And again, depending on the party in power and the ideology that they are driven by, determines what sort of processes and mechanisms and policies are created and deployed. And again, we were the first in the world to have the that experimental injecting room in Sydney. That was the first in the world, and it was what they call a trial. So it was technically illegal by all conventions, but because it was a trial to see what it worked, and it didn't work, of course, and the data around that was spun 6 ways from Sunday, and we've dismantled that. Our sector has dismantled that and proven that to be so. But they keep doing this because those who control policy levers continue to implement their particular, pet projects, regardless of the evidence. But we'll get to that in a minute. But that ministerial position. Again, senior position in a province in Canada is like our states here in Australia. So it's important to use that as a juxtapose for our listeners, some of our Australian listeners. So Canada is part of the Commonwealth, as is Australia, which is great. Go Commonwealth. The bit of a running gag here in Australia. They're still trying to become a republic, and won't go down that road today. But being in that position, and you've articulated the journey to that space, you're a coalface operator. You're invested not just in system and practice and policy, you're invested in changing lives. You're invested in outcomes, your words, that see people's quality of life become better than they argue. This is one of the statements in the recovery sector that we bump into. Better than it was before. The whole restored, functional, not just not unwell anymore, but complete and whole. And that's that agenda. That wraparound service that you've invested for that agenda is sorely lacking. That vision, that mission clarity, has been eroded or completely erased from the public square by these misused policy frameworks and the bad actors who often do that. Now, without putting you on the spot, and with no intention, obviously you had to part company. The resignation or asked to move on? What was kind of the scenario given options?
No, termination. I loved my job. I loved what I did. I did it to try to improve the lives of individuals that were afflicted with these horrible conditions. It was my home province. I wanted to make a change. I have family members that are impacted by mental illness and addiction. I wanted to continue to do this work, and I wasn't permitted the opportunity. However, I wanted to build a system of care with a relentless pursuit of recovery. And so if the policy direction was to only focus on harm reduction is an important part of the continuum, but it's not the only part of the solution.
Perfect. Yeah, look, the reason I bring that up is because I think one of the difficulties that we found here in Australia as well, and your experience has been shared by people all over the world. You've got a great practice, great policy framework. It's working. It's about whole of person care. It's about, again, that relentless pursuit of drug exiting recovery, but more than just drug use exiting, it's entering into a new phase of wholeness and restoration and completeness, which the policies and practices you're advocating for were doing, not possibly could do, might do, were doing. And we saw a little bit of that in Australia under a Conservative government, that we saw a big change. And then all of a sudden another government came in, they literally threw out everything that existed and of course went into damage management mode. Thanks for sharing that. I know that's not an easy thing to do. I know I've had the experience of being dismissed summarily from roles for no fault of my own, but you've carried that graciously. And Alberta, of course, they saw what you were doing, and they're a province that cares deeply for their residents, and not just the substance user and the addicted or dependent person, but their families, their communities, and all that means. It's not about damage management; it's about bringing restoration and wholeness and back into the community. Now, there's a compatriot of ours and I'm going to do a quote here, and this is not for you so much, Kim, but it's more importantly for our listeners. Much of Canada, like Australia, has been manipulated into running with a one-dimensional and ineffective harm reduction policy interpretation. That's what a lot of the gatekeepers in Australia here have done as well. They've compelled us to line up with a particular interpretation of a particular policy component. And what you said was correct. Harm reduction is an important part of the continuum of care. It's to help those, again, our listeners have heard this 100 times, I'll say it again, it's to help those caught in the tyranny of addiction to remain as buoyant and alive as possible so they can exit drug use. The wonderful statement, the classic line, you can't rehabilitate a dead drug user. Correct, but you can't rehabilitate someone you have no intention to rehabilitate either. So you leave them parked in a tragic space. So the policy is okay, and again, harm reduction as a part of the continuum of care with the intent for people to exit drug use is fine. Again, your OSTs and various needle exchanges, not needle distributions, have all got sunset clauses and exit strategies on them so that people are moving out of that spaces. They're not meant to be staying there. And we've told stories previously about that. I won't repeat those here again. But I read a recent excerpt from a compatriot of ours in Scotland who are going through a very similar mess that Australia is experiencing and much of Canada is experiencing as well. Harm reduction without recovery is not balance. It is abandonment with better branding. This is not a solution to addiction. It's an accommodating to it. A quiet lowering of expectations. The ambition is no longer to help people escape the storm, but to provide them with a slightly better umbrella while they remain in it. That's from Anne-Marie Ward, previous guest on the show. What we here on Unnecessary Harm podcast are about is helping communities, families, individuals find the best way forward for restoration and wholeness. And that's why one of the reasons we got you on, Kim, and CORE Canada, because you guys personify the very heartbeat of what we believe proper drug policy should be doing in regard to people who are caught in the tyranny of addiction and communities that are part of that. Just that statement from Anne-Marie, you've intimated that certain things are happening there as well. We've seen injecting rooms here. We've seen needle and syringe exchange programs turn into needle distribution programs, and now we've just got litter. We've got injecting mechanisms, litter everywhere. Tell us a little bit about the juxtapose without I understand the political space in this, but you're in Alberta now, which is great. You've got your own space. They're on board with what you're doing. Tell us a little bit about the juxtapose between the two provinces, for example, Manitoba and Alberta, and how Alberta's tackling this and what they're doing, and with you, and how that's working in as opposed to other spaces in Canada.
Yeah. So, historically, or in more recent years, this has been quite a divisive issue and quite a
Yep.
political issue, with governments even either committing to recovery or harm reduction, and there didn't ever seem to be a middle ground. In more recent years, and almost in the last year or so, we've seen a changing of the tides, with more provinces working towards recovery-oriented systems of care, recognizing that harm reduction is an important part of that, but not the end or not the singular solution. I think one of the things that's important to note is that in the Alberta context, when we talk about harm reduction, we talk about evidence-based approaches that minimize the negative health and social impacts of drug use on both individuals and communities. And it has four main important points. So one, a clear articulation of the harm that that program is intending to reduce. Two, evidence supporting that it actually is effective at reducing that harm. Three, looking at evaluative outcomes for individuals and communities. So reducing harm, going back to the origins of harm reduction, looking at reducing harm to both individuals and communities, not one or the other, as well as evaluating programs not just in the short term, but over the long term, to be able to understand if there is unintended consequences. For example, are programs increasing rates of addiction or increasing severity of addiction? The next point is fidelity to the original research. And so the one that I often cite is around housing first. So housing first is highly effective for individuals with severe and persistent mental illness. It's not effective for individuals with addiction. And so you can't take a model and the original research that applied to individuals with severe and persistent mental illness, where they're housed in scattered site housing, meaning a couple suites within an otherwise healthy environment, supported by ACT teams that are led by psychiatrists. You can't take that model and then apply it to congregate living for individuals with severe addiction without connection into clinical teams and support. And so it's about fidelity to the original evidence and making sure that we have standards to ensure that we're following how it was originally researched and supported. And then the last piece is just this relentless pursuit of recovery in all that we do, including harm reduction. And so in Alberta passed unique law to require the mental health and addiction services and connections to care to be a requirement as part of many of their harm reduction programs. That's not something you see in other Canadian jurisdictions.
Correct. That's brilliant. I think the succinct itemization there is really important. I think that's a good policy framework, and we'll certainly leverage that. Of course, any smart actor will do that. And I like the clear juxtapose. I think one of the things that and I'm using this term specifically and deliberately, the bad actors, they love to convolute. They love to mix and match. They misuse nomenclature to hyperextend meanings or to shift meanings. And you've just hit that perfectly, the difference between the mental health and the addicted person and the home-based processing. Now, it's interesting, you're dead right, 100%. But what we do is what we've done in Australia particularly is we've collapsed all of the recording of mental health and addiction into the one mental health stat. It's all been collapsed into one mental health stat. You can't find mental health because of substance use. You can't find it. It's since 2016, we've done some deep dive searches. They've collapsed it all in. So basically, you have someone off their nut on crystal meth, stabs 6 people in the street. They've got a mental health problem. They're not got a drug problem. They've got a mental health problem. So again, the language is hijacked, it's retasked, and then it's manipulatively used to direct policy focus and attention. And again, you've just demonstrated, and those are listening who are in the policy space, and we're going to be promoting this as well, is that you need to know clearly the evidence doesn't point to that. And if your evidence or the evidence you're looking at says it does, it's fallacious. It's just not correct. Again, we all know this intuitively, but now the evidence is starting to unfold. And as you have said in Canada, people are starting to wake up. But again, everything's about who are the stakeholders controlling the policy levers. So you have policy. In Australia, we have policy, and it's there, and it looks good on paper, but then there's interpretation, and then there's practice, right? So again, and then people say, oh, well, we are doing prevention or we are doing recovery. And then they've redefined the word recovery. And one of the things that we've got going here at the moment, and Delgado Institute's part of that, along with other groups in our task force for prevention, is a reclaiming recovery community of practice, trying to get a lot of the sector actors on our side of the fence who genuinely want to see people exit drug use, understand what's been going on, because the language is being hijacked. And recovery in Australia is now being redefined as terms like recovery is functional, sustained use of drugs with minimum intervention, blah, blah, blah. That's recovery. So again, that's just one of the definitions that's now been thrown up. And we used to talk about lived experience and earned resiliency as part of recovery capital and prevention capital. And now it's been retasked. Oh, no, lived and living experience, people. We're going to tell you how you can keep living with drugs and do it more safely and be more functional in your ongoing drug use, despite your health decline, your inability to sustain ongoing work. You're a functional drug user. So therefore, this is great. This is a recovery. So these are kind of the languages that are being thrown around. And I'm going to drill back into those key points you said, Kim, because I think I want listeners to get a hold of this. Now, we'll use that in part of our presentation later on. But tell us again some of the. I want to try to get some. I suppose real life examples in your world of what you've seen. You've seen the policy work clearly, but what are some of the outcomes you've seen, and what does that look like on the ground for a community that decides that recovery, we use the term drug use exiting recovery, and moving into a community that says, no, we don't want substances governing what we do in our community anymore. What does that look like on the ground for families? What does that look like on the ground for the individual who's escaping this tyranny?
Hey, before we continue, we want to highlight an excellent cousin podcast you should definitely check out. Pathways to Prevention with Dave Clausen. Dave brings incredible, proactive and protective insights that really complement the work we're doing here at UHP. That's pathway number 2, prevention. Make sure you subscribe and give it a listen. Now, back to UHP.
Yeah, so Alberta's got a brilliant kind of system of care, and I always say one of the main reasons why their system of care has been so successful is it's been designed by individuals that are in recovery themselves. So they've gone through this process. They understand where all of the hurdles are, the roadblocks, the artificial barriers, the red tape, and what needs to be worked through in order to help individuals and families be well. And as a result, the system is designed around the individual and the family, not around the provider. And so we've still got more work to do, but that's, I think, a key element of why this system works so well in Alberta. And from kind of some of the successes that we've seen, so historically, and something that you'll see in other jurisdictions across the country in the Canadian context, is that if you decide you're ready to make a change or you want to help your loved one make a change, you probably have to present to a rapid access to addiction medicine clinic, so an addiction clinic. In my home province, the rapid access to addiction medicine clinics were opened on limited hours, like let's say Monday, Wednesday, every other Friday from 10 to 2. So if you're somebody that's very living a very disorganized life, you're on the street, you decide you want to make a change, you have to be organized enough to show up, wait in line, be the first in line, and be seen during those limited times in order to be able to start on the path to recovery. In addition, you potentially need to have done your taxes in order to qualify for some sort of pharmacare benefit in order to be able to afford your opiate agonist therapy or your addiction treatment medication.
Yeah.
In Alberta, they've designed the system around the individuals. And so Alberta's got a gap coverage program, means that any physician can prescribe opiate agonist therapy at no cost for that individual for a period of time until they're able to work to stabilize out their life and get other benefits in place. They've also introduced a program called the Virtual Opioid Dependency Prescribing Program, or VODP program, which allows for immediate access to life-saving opiate agonist therapy virtually, anywhere, anytime, any place, including connection into an addiction medicine physician who will prescribe that medication and an interdisciplinary team to support you to work through your other issues over the long term. Since introduction in 2017, they've seen over 17,000 unique individuals through this program. And then more recently, the program's expanded into very atypical settings. So now it's used as a bridge to help support people during periods of transition. So whether they're leaving a detox program or they're leaving a hospital setting. It's also been introduced in very atypical settings. So supervised consumption sites. It's been introduced in correctional facilities. So the day somebody enters into a federal or into a provincial prison, they can get started on a long-acting injectable buprenorphine in order to get started on their addiction treatment path or their recovery path on day one, not the day they're leaving the facility, but the day they enter into the facility.
Perfect.
And then I had the privilege of touring one of the police centers more recently, and they even have it as an option to start in police cells, where you can connect in from the police cell with the addiction physician and get started at that point in time. So interestingly, we're now starting to see a lot of people coming in to correctional systems that are stabilized and no longer in active withdrawal because they've been able to start on OAT before they even get there. From the correctional setting, we've also seen significant improvements in overdose deaths in more recent years. Several years ago, about 40% of the overdose deaths in Alberta were related to individuals that had had a recent stay in a correctional facility. So, and that represented the largest kind of single group of individuals amongst those overdose deaths. In 2025, there was a 70% reduction in overdose rates for individuals that were leaving a correctional facility up to 1 year post-release. And interestingly, at the same time, we saw about a 40% reduction in overdose deaths across the province at the time that the rest of the country saw a 19% reduction in overdose deaths.
Yep.
Now, the country's made up of about 10 provinces plus territories. If you actually remove Alberta from that number, Alberta was down 39% in 2025 compared to 2024. But when you remove Alberta from the Canadian numbers, the rest of the country was actually only down 5%.
Yeah.
So it was a marked reduction in overdose deaths.
Interesting, isn't it? We had a visitor from a Canadian politician. Now, I think his name was a certain name, but I won't, in case I mispronounce it. He used to be a high-up policeman who became a politician. He was also a board member of a big cannabis company. And he came out to Australia to talk about injecting rooms and, talking about their capacity to reduce drug harms. And again, we know from the data that's been flying around for a while now inside the injecting rooms, it's been, undone. One of our Australian researchers here unravelled that with Lancet, actually. Took them to task and years ago and found that their the research was just faulty, and the stats taking was faulty. This gentleman was in a room, and the room was about 30, 40 people. I was probably the only preventionist in the room. There was a couple of recovery people in there who were working in this space, and the question was about consumption rooms. Shooting galleries is the pejorative term. Consumption rooms, drug consumption rooms, which we had one in Sydney and now we've got one in Melbourne, which is an absolute disaster by every metric. It's a complete disaster. And he made this statement about, we had this great success. I said, well, okay, I'll talk about saving lives. Has this led to drug use, to recovery? Oh, yes, he said. And I said, oh, really? So I looked at your site trying to find the stats. So we've had over 800 people led into recovery because of our injecting room. I said, really? I said, that's fascinating. So they no longer use drugs anymore. He went quiet. So they're completely drug-free. He went quiet. Next question. So again, the data, the stats that he was presenting were recovery was, no, they hadn't exited drug use. They were just using substances more on a lower level, avoiding overdose, and therefore they're in recovery. Now, they're on the journey towards recovery. I have no problem with that. But to call that recovery was one of the issues that we found really problematic. And again, this is where language is hijacked, retasked, and reframed for the purposes of selling a particular model. Now, I no doubt you would have seen that because Insight, is that the name of the injecting rooms that they have over there? Is that right? Sorry?
That's the name of one organization
Oh,
that
okay.
runs
Sorry.
one
Yep.
supervised consumption site in the country. In the Canadian context, there's about 40 approved supervised consumption sites. However, the Canadian government has also granted authorities to the provinces to open up urgent public health need sites or overdose prevention sites, and there's no public record of those. So if I had to project the number of those, it's likely hundreds of them. And so Insight is one of these many sites that exist across the province or across the country.
Yeah. So again, those mechanisms are obviously harm reduction. Do they actually, all those different offerings that are being rolled out or presenting, do they tie into the mechanism that you're talking about, or they just operate separately as a purely damage management tool?
Yeah, I mean, again, harm reduction is an important part of the work that's happening in Alberta, but it's also really important that we evaluate the programs to understand if they help or if they're making things worse, and we look at outcomes kind of over the short and long term. In the Canadian context, in order to operate a supervised consumption site or an overdose prevention site, you aren't actually required to collect health identifiers from the individuals using the site. You're only required to have some sort of sign-in information. So I could come in under your name or somebody else's. There's no verification of my identification. And so when people say that nobody's died in a site or we have really good outcomes for our clients, it's really hard to know because you don't actually know who's using your services in the first place.
Correct.
And therefore what happened to them. In addition, under Canadian law, there's no requirement to have a healthcare professional on site. So if somebody overdoses and dies, there's nobody on site that will proclaim a death. And so this popular narrative that there's been no deaths in supervised consumption sites is fraught with concern. There actually is documented evidence in the peer-reviewed publication dating back many years, but this coupled with the fact that we don't actually know who's going through these sites or have clinical expertise in order to proclaim death, that's a really flawed claim. Several years ago, Alberta actually introduced a law, though, which is a provincial law requiring collection of health identifiers, not necessarily the requirement to present a health card, but enough identification or identifiers like your name, date of birth, in order for the individual working at the site to link you back to a health number. Our organization has now been able to access all of that data, and then we were able to evaluate the impact of an overdose prevention site closure on actual site users and compared that to a site that didn't close. And so recently we had that publication published in the journal Addiction, and our study found that there, and so we were able to look at about 300 clients from about both sites, which is a capture rate of about 95% of the site users. So historically, research is based off of either community level data, which includes people that will never use and have never used a site, possibly like you and I, or it relies on voluntary involvement in the study. So most likely people that are doing well. In our case, we were able to look at the majority of clients, almost all of the clients that were using the site. So after the site closed in Red Deer, we did not see a statistically significant increase in the number of emergency department visits, the number of emergency medical service calls, and there was 6 deaths in the 6 months prior to the site closure and 5 deaths in the 6 months post-closure. And then what we did see, though, which was quite a surprising finding for us, was that there was a statistically significant increase in the number of people connected to opiate agonist therapy at the time that they announced the closure of the site, and then again after the site closed. And so that was a surprising finding because we've often been led to believe that these sites, 1, reduce use of healthcare resources, 2, save lives, 3, connect people to care. And our study didn't find that. And so there's more work that needs to be done. We need to understand this over the long term. We need to understand this across more sites. But this is interesting early findings that we can't ignore. And we need to help unpack this a little bit further.
Perfect. I think that's one of the issues here we've got in Australia, this genuine investigative evidence-based research around evaluating these mechanisms. It's not about trying to prove them bad or good or whatever. It's about evaluating their claims and what they're supposed to do and what they're supposed to produce. Now, we saw that in Australia as well. We saw our injecting room in Sydney get all these evaluations, yet when we did a scrutiny of that data and we juxtaposed it with other evidence, that was ignored or left out, we found that the injecting room wasn't doing anything really what it was proposing to do. And the same with the Melbourne one's got even worse. We've got more drug dealing going on, and this is not just anecdata; it's becoming very problematic. So, again, but the research needed to be done to do what you've done to properly evaluate this is not allowed because those holding the levers of policy are not letting that happen. So again, the same people bring the anecdata to bear. They throw in some selective cherry-picked bits of information, and they say this is what's happening. Yet the community and the media and the police are coming out with all sorts of other statistics and data going, this is chaotic. It's not just for the public health system, but for the criminal system. We've got drug dealing going on. We've got deaths, and we're very careful about the word overdose here at Delgado. I just want to put that out to our listeners, and for Kim's sake as well. I mean, she's dealing with the clinical space. You cannot overdose on a non-prescribed substance. Yes, you can overdose on morphine because that can be prescribed. You can overdose on OxyContin because that can be prescribed. Everything else, an illicit drug is not an overdose, it's a poisoning. It's a flat out, you are taking a poison and it's killing you or potentially killing you. So again, we're going to belabor that point because we love that language is beautiful. Oh, we've prevented overdoses. You prevented a poisoning from having its fatal outcome, which is a wonderful thing. No one's arguing that. But what are we really doing here? Are we helping people? And this is where getting back to what you're doing at CORE and what Alberta's implementing is brilliant. This is all about not just exiting substance use, but it certainly is about cessation of it. It certainly is about not accommodating it, celebrating it, enabling it, equipping it, endorsing it. It's none of those things. And it's about helping people exit drug use into an arena, into a life and a trajectory that is proactive and positive and wonderful. And that wraparound care that your services are offering is from the very start to the very end, which is what's needed. Damage management mechanisms are only one-dimensional, and as whilst they are important in the continuum of care, going to labour this point, people, for the sake of the audience out there who know our particular ilk on this, harm reduction remains an important pillar in our national drug strategy if it is tasked correctly, used correctly for the purposes of helping people exit drug use, not maintain, sustain, and equip ongoing drug use. Anyway, I have a little rant there, Kim. I have my rants every now and then. That's nothing to do with you. Kim's got no part of that. That's a Shane rant. Delgado rant. Anyway, that's really brilliant. That paper, it was a ripper, and I think I will put you in contact with one of our researchers in a fellow organisation who did some really good work on the injecting rooms in Australia. And Gary, he's a research fellow and now the president of Drug Free Australia. Brilliant researcher and brilliant evaluator of products and policies. Kim, I'm having a little rant. I'm calmed down now. I'm back in the zone. That's all good. We have a question. I'm looking forward to ongoing connections with you guys and the Canadian group there. It's really fantastic. We have a question we ask nearly all of our guests at the end of our session. It's a standard question to ask them. A fence or an ambulance? A fence at the top of the cliff or the ambulance at the bottom of the cliff? Which is your preference, or is it both?
Oh boy, yeah, I've heard the analogy around rivers and pulling bodies out and preventing them from falling in. So yeah, absolutely, it's a continuum. It's absolutely everything. And on the harm reduction, I heard someone say once, if you ask 100 people who have loved ones that have addiction what they would want for that individual, 100% of them would say recovery. So I don't understand why this is such a contentious issue. I'm glad the tides are changing. I think we can all agree that we need a continuum of care that encompasses all of that, helps people meet where they're at, but doesn't leave them there.
Perfect. Good answer. Wonderful answer. It's not just politically correct. It's not just trying to find the middle ground. It is an exact answer. And because that's exactly right. Recovery is the goal. Once recovery is taken off the table as drug use exiting into a life of fulfillment and drug free, if that's taken off the the table, we're no longer talking recovery. We're just talking
Yeah.
damage. We're
Well,
just
if one
talking
of the most important things when it comes to mental illness or addiction recovery is to have hope, you need to have hope in all the programs that you do, and leaving people paralyzed in addiction does not give them hope.
Perfect answer. And that's one of the definitions that we have in our resiliency building platform, is that all of these resiliency is a combination, a wonderful combination of problem solving skills, persistence of will, the capacity to endure, all founded on hope. Now, hope is not just the positive expectation of good, it's the reasonable grounds for it. What CORE in Canada does, listeners, is genuinely not just talk about hope, they are the reasonable grounds. They are enacting reasonable grounds so that people can have a positive expectation of a future that is drug-free. There's communities that can be healthy and whole and complete and functional, and that individuals and families can really enjoy life to the full without the tyranny of substances in their world. So again, Kim Kaufmann, CEO of the Canadian Centre of Recovery Excellence. It has been an absolute joy having you on, and thank you for putting up with my rant. It's every now and then our guests get one of those, and you're the other end of that. But it's been really good having you here. Looking forward to having you back on again, I think, in the future, and talk about the development, what's happening in Alberta and the successes in your communities. So, thanks for being here. It's been really, really special.
Yeah, absolutely. Thank you so much for inviting me to this podcast and having me here today. I'd be delighted to come back and or help connect you with anybody within our organization to speak, or others in this space as well. If anybody has any questions about CORE, we've got a website, recoveryexcellence.org. You can reach out to me or any of our leadership team. So thank you so much.
And we'll be putting all those details on their podcast, on our platforms all over the place, promoting CORE and Kim's work, fine work with her team. Okay, until next time, folks, remember, not just avoid unnecessary harm, but be part of the solution. Be a proactive and creative agent in your community. Make a difference today. Until then, bye.
As we wrap up today's session, remember, each step towards understanding is a step away from unnecessary harm. We're here to empower, inspire, and pave the way for optimal well-being. Stay resilient, stay informed, and continue being the change your community needs. Thank you for joining us at the Unnecessary Harm Podcast. Until next time, take care and keep pushing forward.